Good evening. Hi, my name is Tom Dudney, and we'll be talking about provisional fabrication and mock-up techniques with and without a diagnostic wax-up tonight. Some of the techniques we'll be talking about are an intra-oral lock-on provisionals utilizing a wax-up. We'll be discussing extra-oral finishing provisionals with a wax-up. We'll be talking about a direct intra-oral mock-up technique when you don't have a wax-up, an indirect intra-oral mock-up without a wax-up, and then an indirect intra-oral mock-up if you have a wax-up. So a lot of different techniques we'll be covering tonight, a lot of different ways we make provisionals. I thought what we would do is start out by talking about the benefits of provisionals and why they're so important when we're doing anterior aesthetic cases. First thing is we like to call it the trial smile. The benefits of provisionals, one of the most important things is it allows the patient to see exactly how they're going to look. So it's a template for the finals. So that means laboratory communication. We can give them incisal ledge position. We can talk about length to centrals. We can talk about the color of the restorations. A lot of important information for the laboratory. The shape and arrangement of the teeth. All of this can be communicated via pictures and impression of the temporaries that we forward to the laboratory. As far as the patient goes, it's critical for feedback and acceptance from the patient. They'll tell us if they like the shape of the teeth, if they like the color of the teeth. It allows them to view themselves in their smile with what the final teeth are going to look like. And if they accept it and they sign off on the provisionals, it's pretty easy to take the guesswork out by giving that information to the laboratory like we just said. They can say things like, I think they're a little too long, or I don't think they're long enough. I like one side better than the other. I don't usually ask the patient, do they like the right side or do they like the left side? I'll ask them, do you like one side better than the other? And this is information that can be communicated. As far as color goes, we'll ask them things like, do you like the color? If they say, I wish it was whiter, when we know we can bump the shade up a little bit. If they feel like the shade's a little too light, we know we can tone it down some. It also allows us to, it's important also for the dentist because it gives us an opportunity to evaluate the aesthetics of the case, which is of primary importance, as well as the function. We can go through speech and F and S sounds, things like that we'll talk about in a minute, and allows us to see if they have any parafunctional habits, possibly if they're breaking temporaries. We can adjust for that before we get into the finals. As far as the mock-ups, the mock-up technique, which we'll be discussing tonight, I love to do intra-oral mock-ups because it gives me an opportunity to visualize the case before we ever begin, and it gives us a chance to see what they're going to look like, or gives the patient a chance to see what they're going to look like before we ever start. It can also, one of the most critical things, to me, the single most important thing when we're doing anterior aesthetics is to establish the incisal edge position. Most often in cases we're doing, the teeth are going to need to be lengthened, and we need to know where the incisal edge needs to be, both in a coronal incisal to gingival length, but also from a facial lingual, or from the buccal edge to the lingual position. We also need to establish the incisal edge. It's very critical. It can help us establish proper arch form. We can be used to establish gingival height symmetry, tooth proportions, facial contours. We'll show some examples of these with clinical cases. It will aid in evaluating the aesthetics and the function of the phonetics before we ever even get to the provisionals. And it can be used as a template for the provisionals in the absence of a wax-up, and we'll show some examples of that. It could be beneficial for laboratory communication. If you don't know the incisal edge position, you want to establish it, but then you want to create your provisionals with a wax-up. You can determine incisal edge position with a mock-up, communicate that to the laboratory, and they'll use that information to fabricate your wax-up. And it can be beneficial for patient feedback before you ever begin the case or commit to treatment. The last thing is, sometimes if you're pretty good and it doesn't take a lot of time and you don't have to adjust any tooth, you can use a mock-up as an opportunity to go ahead and show, maybe let a patient preview what they would look like and helping with case acceptance, somewhat like a computer image. The only difference in computer imaging and doing a mock-up on a patient is it's a little bit more time consuming. You won't be able to touch the teeth if they haven't accepted treatment, but it does allow them to see themselves rather than in 3-dimension, rather than what a 2-dimensional object like a picture you would get from a computer mock-up. So let's start with some provisional techniques. Well, the first one we're going to look at is utilizing a wax-up, and the two primary techniques we use for provisionals is the lock-on technique and the extra-oral finishing. In our lock-on technique, the primary reason why we use a lock-on technique is if we're doing no prep or very minimal prep veneers, and the restorations are going to be very thin. It's difficult to deal with these outside of the mouth. So I like to use a lock-on technique because the temporaries are actually fabricated right on the teeth, and we'll show you how that works. To begin with, we'll go through step by step what each of the steps in the procedure are, and then we'll show a clinical example. The first thing we do is we clean the preparations, and I use some type of chlorhexidine like Conceptus or something like that. Then we're just going to spot etch the teeth right in the center of the tooth, away from our margins, and this helps maintain the provisionals while we're having the final restorations fabricated. We're going to rinse and lightly air dry, and then we're going to paint that spot etch with some type of a bonding agent, and we're going to light cure. It could be any of the unfilled resin. It doesn't need to be a fifth generation with a prime end bond. It can just be a bonding agent like a 2FL or something like that. We fill the putty matrix that we have that's made with from the diagnostic wax up, and we seat that over the preps. Then we allow that to set for a couple of minutes. We remove the putty matrix, and the provisionals will be on the teeth. There'll be some excess, the gingival margins, and there'll be some excess in the lingual, and we'll go ahead and we'll trim those excess from the margins, and then we'll adjust the occlusion, we'll do any shaping, open the embrasures, polish and paint glaze. So those are the steps, and let's look at it clinically how we would do it. So here we see a case where we're going to be doing some minimal prep veneers. We have the diagnostic wax up, and we also have the putty matrix. The putty matrix is made out of Siltec putty. This is an Ivoclar product, and it's made right over the diagnostic wax up, and we'll use this to fabricate our provisionals with. So we've finished the preparations, we've made our final impressions, we've got our bite registrations, everything we need, and we're ready to fabricate provisionals. We're going to clean our preps with some type of chlorhexidine rinse. We're going to rinse this off to this antimicrobial agent to disinfect the teeth, and then we'll go ahead and we'll spot etch the teeth. We put a little etch of phosphoric acid gel right in the center of the tooth, allow that to sit for about 10 or 15 seconds, rinse that off, lightly air dry, and then we'll come back and we'll paint those areas with some bonding agent. We're now ready to go ahead and seat our provisionals. Seat our matrix. We'll go ahead and put some material, provisional material. In this case, we're using Pulp Dent's Tough Tint material, which I like a lot, and also DMG has a great product, and their Zenith product is a really good product. We use that a lot of times too, and Luxa-Temp is their temporary material. We go ahead and fill our matrix, and one little caution here: if they're a very thin veneer, if it's a minimal prep veneer, you don't want to put a lot of material in the tray. That way you'll have a lot more excess. So just put a small amount just in the facial surface of the matrix. And then we'll go ahead, and here we see the Tough Temp, and some of the things I like about it is it's got the new rubberized urethane technology. It self-cures with a light cure option, meaning that if you use a clear matrix, you can go ahead and light cure. You don't have to wait for it to self-cure. It's tough and fracture resistant. It's good for long spans, and it doesn't shrink or distort, which is also beneficial, especially if the restorations are going to be in the mouth for a while. Grips the tooth tightly, and it doesn't. It's very easy to trim. It doesn't gum up the burrs when you're trimming it, and the fluorescence adds some aesthetics to the final temporaries. So after it's been in for about 2 minutes, we're going to remove the matrix, and we're going to see our temporaries, and we'll see a little bit of excess gingival, and every now and then we're going to see a little bit of you might get a little void or a little bubble or something like that, and we can take some flowable composite, and most of these temporary materials have a compatible flowable composite. It's really easy to fill these little bubbles or voids in, and then we're just going to shape these, and we're going to trim away the excess. I like to use this these little Brasseler burrs. This is the 6844. I use this for most of my facial reduction. If we use this more for mock-ups, if you have a wax-up, as you saw from those temporaries, you're really not going to need to do a lot of shaping of the teeth. This burr comes in handy when we get to the mock-ups in a minute. I'll show you how we use this burr. But what I do use is for lingual contours and occlusal adjustments, we use the 8368. The red stripe, it does a nice job of shaping linguals and adjusting occlusion. And then for the embrasures, to open incisal embrasures and gingival embrasures, we use this little burr we call the mosquito burr, the 8392. It's got a little point on it, and it gets into the gingival and incisal embrasures really nicely. And we'll show you what we're talking about in a minute. And we also use some discs. These are the 3M discs, the Softflex discs. For heavy contouring, you can use the darker orange ones, and for lighter contouring, there's The yellow ones are much finer grit and don't take as much temporary material away. So what they look like up close. After we've got everything shaped the way we want, we'll go ahead and lightly dry these, and then we'll paint a glaze. And here we are painting our restorations with a glaze. Here are the final temps, just to look at what they can look like. So this is the information that we're going to send to the laboratory and we're going to use for patient feedback. So the next technique we're going to look at is the extra-oral finishing. This also is being done with a diagnostic wax-up. The reason we use this technique as opposed to the lock-on technique is sometimes the preparations may not be minimal prep. We might have crowns that are already on the teeth. We might have interproximal restorations or decay we're removing. They may be onlays, onlay veneers, more aggressive type preparations, and it's very difficult to trim these and get the interproximals trimmed if you use a lock-on technique. So we're going to actually do a technique where we finish out of the mouth, and after we've shaped up our interproximals, we'll cement these back in after trimming them out of the mouth. And we'll show you how that. First we'll go through the steps in the extra-oral finishing. Everything is the same except that we don't etch the teeth to begin with because we don't want these to lock on. So the first step we're going to do is we're going to apply a separating medium to the teeth. This just keeps the material. Sometimes these the temporary materials have a little bit of a grip factor. So what they do, they might lock on an interproximal, making them difficult to remove if you don't use some type of separating medium. Anything, I don't recommend Vaseline. Anything that's water soluble, it's easy to rinse off and will keep the material from sticking to the teeth. Then we're going to take the putty matrix just like we did before. We're going to put our temporary material in there. We're going to seat it over the preps for about 1 to 2 minutes, and then once we feel that it's set, we'll go ahead and remove that matrix. And before you remove the temporaries from the matrix, go ahead and let them sit. We call that bench curing for about another minute or two. They can be a little bit fragile and easy to distort if you take them out too quickly. But it's nice not to leave them in the mouth too long because they won't lock into the interproximals that way. So we're going to carefully tease them out. You can have your assistant kind of help you. She'll tease that putty matrix out while you take some cotton forceps or something to tease the temporary out of the temporary matrix. And then we're going to go ahead and trim the excess, the gross excess. Don't do your final trimming till you try it back on because you just want to make sure it fits before you do your fine trimming. But any gross excess, you'll go ahead and trim that away right away. Then we can do one of two things. If you have veneers or 3/4 veneers or something like that in the anterior, you might want to spot etch and put it on with some type of flowable composite. If they're full crown preps, we can use some type of non-eugenol temporary cement. There's just different techniques, different ways of doing this, but it's similar to just what we showed before, except that we're actually going to be cementing these on instead of locking them on the teeth. So we're going to paint the internal surface of the temporaries with some type of bonding agent. If we are going to use a flowable composite, then we're going to fill our temporary with the composite and we'll seat it over the preps, wipe away the excess, and light cure. This is slightly different if you use a non-eugenol temporary material, and then you would just go ahead and fill your temporary, wipe away the excess, and allow it to self-cure. And just like before, we're going to finish our margins, shape and contour. We'll adjust our occlusion, we'll polish, and then we'll paint with glaze, similar to what we just saw. So here's a case that we did, and we're applying some, in this case it's liquid strip. You can use Wink. There are a lot of different products out there. They all work well. Deox, some of these, it's just a glycerin. It's water soluble. We paint it on over the preparations, and it keeps the temporary material from sticking to the teeth. We're going to take, just like we saw before, our putty matrix. It's made from the diagnostic wax up. We're going to go ahead and fill this now. In the cases where you're doing full crowns, you might need to put a little bit more material in than you would for a veneer. And we're going to seat it over there for 1 to 2 minutes. Once it's set, you can go ahead and remove it from the mouth, and the material stays in the matrix. It doesn't stay on the teeth. It's because of the separating medium. So allow that to sit another minute or two, and then you tease the matrix outward and then just kind of slightly tease it out. You can see we have a little bit of gross excess here. We're going to trim away the gross excess, and then we'll go ahead and try it right back on to check our margins and make sure the temporary goes to place. Then we know it's fitting, we know it's seating well. Then we'll go ahead, and in this case, we're spot etching the anterior teeth, and we're not on the posterior teeth because we have good retention back there. And same thing before, we're going to paint our bonding agent just like we saw with the lock-on technique, and we're going to fill our temporaries. In this case, we did it in segments. We had 2 posterior segments and an anterior segment, and here we are painting the temporary, and then we'll put a little flowable in there. We'll seat that over the preparations, wipe away the excess, let it fill in any voids, clean away the excess, and then we'll light cure that. Then we can go back just like we did before. If we have some little voids, we can fill those in. If we have some little corners that didn't fill all the way, we can add size of length. We can do any kind of temporary adjusting we need to by adding material with flowable composite. Same birds as before. And here you see how we would do facial contours with the 6844, and then the 8392 mosquito we see in the bottom picture there, where we see that we're taking that and we're opening the gingival embrasures and the incisal embrasures, and then we contour with our 3M Softflex disc. Once we've got that everything shaped just like before, we'll go ahead and we'll paint our glaze. There's the burrs that we're using. The 8392 is the mosquito at the bottom, and the 6844, the 014. I like the 014. The 016 is a little too thick, and it doesn't shape as well. And when, like I said, we get into mock-ups where we're having to overbuild teeth and shape them in the mouth, this burr can come in really handy. So now we've adjusted our occlusion, we've polished, we go ahead and paint our glaze and light cure that, and now we're going to be able to get the patient back and we'll be able to evaluate these. And the first thing we're going to evaluate is the aesthetics of the case. Primarily, most of the patients, when they're doing these anterior cases, they're coming because they're unhappy with the appearance of the teeth or their smile. So the first thing we're going to do is we're going to go through our smile design principles, and we're going to evaluate things like incisal edge, incisal display, smile arc, gingival symmetry, axial inclinations, contact areas and embrasure form, tooth proportion, and buccal quarters. These are all of the things that we see from our smile design principles that we are able to evaluate in our provisionals to see if it satisfies the requirements of being acceptable. And if it is, and we know that the patient's happy, we feel very confident when we go ahead and confirm that with the laboratory via pictures and via impressions of our temporaries that we're going to be able to satisfy the patient from the aesthetic standpoint. But we're also going to check the function, and because if you see this case right here, we have no overbite, no reject, we have no anterior guides. We're going to be creating this in the final restorations where we would like to know if our new occlusal scheme is going to work. So we're going to evaluate our incisal guides, we're going to evaluate canine guides, we're going to evaluate overbite and overjet and vertical dimension if we're opening the bite slightly. All of these things we can work out in the provisionals, and that's what makes them so critical to the final result. And so it's not just the aesthetics, but we're also going to evaluate function, and we're also going to check and make sure the patients can speak. We'll look at F and B sounds. We'll have them say 55, 44, count from 40 to 45. We'll look at S sounds, have them say Mississippi, count from 60 to 66. And we're going to check these things. We're going to check phonetics. So the three main areas we check are aesthetics, function, and phonetics, and all of this can be done in the provisionals. And if the patient's happy and they like the color, we take pictures, we take impressions, we forward that onto the laboratory, and it's critical for the success of the case. So here we see the pre-op, here we see our temporaries, and here we see the final restorations. And again, if we look at it retracted, the pre-op, the provisionals, and the finals are very similar to the temporaries simply because the patient was happy with them. They were satisfied. Functionally and phonetically, they worked fine, so we felt very confident in going ahead and committing to the final treatment. And that's the benefit that we know in taking the guesswork out, and that we don't have to sit there and wonder, oh, I hope this is going to work, or will they tear them up, or are they going to be okay with the new vertical dimension and things like that. So let's move on into the mock-up technique. Those are the two main ways we make provisionals. We use the lock-on technique when we have very thin, minimal preparations, and we use the extra-oral finishing technique if we have more aggressive type preparations. As I said at the beginning, I like to use mock-ups a lot of times because it helps me get diagnostic information before we ever begin the case. There are different ways we do mock-ups. My favorite way, because quite often I'm doing this, I don't have a wax-up yet, and often I'm doing this, and I'll use my mock-up in place of the wax-up, and we'll show you how we do that. So the first technique we're going to look at is a direct intra-oral mock-up without a wax-up. So this patient comes in, she's unhappy with her smile, she's looking for some aesthetic options, and we're going to try to look at this and evaluate the case. Now, obviously, we could give her an idea of what we could do simply by doing computer imaging, and we could image a smile. The only problem I have with computer imaging is that it doesn't always tell them exactly how they're going to look. Even though they see the teeth in their face, it's usually teeth from a library, and it may or may not be beneficial. Sometimes it is, but it certainly doesn't let them evaluate it like a mock-up on their teeth would. Now in this case, if for example you were going to get a diagnostic wax up, you could take, if you've established your incisal edge position and linked to central, then you could go ahead and you could, even without a mock-up at all, just in this case to the laboratory and just ask them to provide a diagnostic wax up for you, and they could wax this case up and determine tooth shape, proportion, gingival symmetry, those type of things. But because we were in a hurry with this case, we didn't have time for a wax up, the patient was coming from out of town, wanted to get started right away, we wanted to evaluate it and see how it would look and see if we could get our tooth proportions and all of those things without having to wait for a wax up to come back from the laboratory. So what is our problem list? Well, she's congenitally missing lateral number 10. She's got canine substitution number 11 in the lateral position. We've got a peg lateral number 7. We have spaces and unsafe tooth proportions because of the peg lateral and because of the canine in the lateral position. And we have gingival asymmetry. So what we do in this case right here is we're going to do a direct mock-up. And this patient has already accepted treatment because we're going to have to actually drill on her teeth a little bit. I told you earlier that we couldn't do a mock-up if you're going to have to touch teeth if patients haven't accepted treatment. In this case, the patient has, but we can still mock it up without any local anesthetic yet, so we can look at their lip position, we can see them smile, we can have them go through phonetics and make sure they can speak with the teeth before we ever numb them and start the preparations. We're going to walk you through here how we do the mock-up. I like to use flowable composite. You can sculpt it with regular composite. I'll take some old flowable, something that I'm not going to use because these are going to be taken right off the teeth, and I overbuild. I just take the flowable, I just squirt it on the teeth. I overbuild these teeth because I can shape faster with a burr and a handpiece, because I'm used to doing that, than I can trying to sculpt and shape. There's absolutely nothing wrong with using sculptable composite if you feel more comfortable doing your mock-up that way. So here we are, we've applied the composite, the flowable, we've light cured, we've overbuilt the teeth. Now I'm just going to take that 6844 burr, the 014 that I told you I like, and here it comes in really handy because we're going to have to do some gross shaping here, unlike we would if we had a diagnostic wax up. So here you see the after, and we've taken these and we've shaped the teeth. We've got the gingival symmetry acceptable. It may not be ideal because of the gingival position of the canine, but we've got the tooth proportions better, the facial contours better, and we've closed all the spaces in. We've set our incisal edge position and our gingival height contours. And now we're ready to go ahead and take an impression of this, and we can use that for our provisional matrix in the absence of a wax up. So we're going to do, the first thing we do is we'll take an impression, we'll set it aside, we'll use that later for our provisionals. Then the next thing we're going to do is we're going to, since we have some gingival adjusting, we're going to take our diode laser and we're going to actually trace the margins of our mock-up so that it will tell us exactly where we need to do our gingival recontouring once the material has been removed. And then we'll take our depth cutting burr. Since our arch form has been established and our facial contours have been established, we have ideal facial symmetry. We're going to go ahead and do our depth cuts through the mock-up before we take the material off. And here you see in the first slide, we've taken these depth cuts, we've depth cut through the mock-up material, then we'll take a little pencil or a indelible marker or something, and we'll just go ahead and color in those depth cuts so that when we remove the material, we can see exactly where they are. So here's the, after removing the material, we go ahead and we know where to prep, we know where our gingival symmetry needs to be, we know how much facial reduction we need and how much interproximal reduction we need based upon our mock-up. And then here are our provisionals that are made from the impression we made of our diagnostic wax-up, of our mock-up, because we didn't have a diagnostic wax-up. So here's our pre-op view. Here's our provisionals, which are going to serve for the blueprint of the blueprint for the final, and it's going to tell the laboratory exactly what we need after patient acceptance. And then here are the final restorations that were made from the impression and pictures that they got of the provisional restorations. The next technique we're going to look at is the indirect intra-oral mock-up without a wax-up. So you might be saying to yourself, well, you know what, it takes me too long. I've been doing this for quite a while, and I used to make my own temporaries. I used to freehand my own temporaries. I used to do a lot of direct composite before we did more porcelain veneers, and I got used to kind of shaping teeth. But a lot of younger dentists or dentists that haven't done a lot of direct mock-ups in the mouth or a lot of direct composite and don't feel as comfortable shaping teeth, it might take you a little bit longer, and you don't want to appoint that much patient time. So without sending to the laboratory for a diagnostic wax-up, you could mock-up, do an indirect mock-up simply by taking an impression of the teeth. So here we see this patient right here, and what we're going to do in this case is this patient is, again, somebody that's in a hurry, is ready to go. The treatment plan has been accepted for 10 veneers. We're going to get started right away. She's coming in from out of town, and we have limited operatory time. So we're going to take an impression, we're going to pour up models, we're going to get her back the next day, and that evening when you have more time, you can make an indirect mock-up, an indirect wax-up. You can do it either with wax, just like they would in the laboratory, on the model, or you can do it as I did here. We're showing I actually did it with composite. Full Composite, the same way I would do it in the mouth. And we did that in this case. We took the model work and we went ahead and we mocked it up on the model. If you do this in your office, you can take more time than you might want to do, and you don't have to feel like you're in a rush as you would if a patient's sitting in your chair. Now here's the before and after. Here's our arch form, which was pretty good. Here's the teeth arrangement. What we're mainly doing is size and shape and closing spaces in. So here's the picture in the lower right-hand corner, the occlusal view of the mock-up on the model. Now what we do is we're going to make our own putty matrix, just like the laboratory would of the diagnostic wax-up. We're going to make our own putty matrix from the diagnostic wax-up of our model that we mocked up ourselves. And here it is. Here's a putty matrix. You can do this with a lot of different materials. This is Ivoclar's material that they use, the Siltec putty. We reline it with a light body to just give us better definition of our provisionals when we make them in the mouth. And then we filled the matrix like you saw earlier. We prepped the case and we go ahead and we put it right over the teeth. But initially, if you want to mock it up and see how it looks, and you want to establish your contours before you make your provisionals, we can mock it up what we call an indirect mock-up. So this matrix that we've made can be used twofold. One, it can be used for the provisionals, and it can also be used to do an indirect mock-up in the mouth, where it takes you no time, just a few minutes, just to put the material in there and just place it right over the teeth. And that's what you're seeing in this upper right-hand corner. The next thing we do, just like we did in the case before that, is once we've established the facial contours and the tooth proportions, we'll go ahead and we'll do our depth cuts through the teeth before we remove our mock-up material. So we've depth cutted here, we've marked those, here we've marked it with red pen, and when we remove the material, we know exactly where we need to prepare the teeth and where we don't need much facial reduction. It really helps us not over-reducing or under-reducing teeth. So after our preparation is completed, as I said earlier, we'll go ahead and take that same putty matrix, we'll fill it with the same tempering material again, whether you use something like Tough Temp or Luxa-Temp, or there are a lot of good Pro Temp. There are a lot of really good materials out there, and they all work well. And we've filled the matrix, not to belabor it, the same way we did before, the same way you saw in the previous slide. We put it over the teeth preparations. We used a lock-on technique here, and then we remove the matrix, we trim them up, we polish them, and here's the patient after. So we were able to get some good information by going ahead and mocking this up before we began. It helped us with our tooth preparations, and the mock-up also helped us providing a matrix for our provisionals. So once we were done preparing the teeth, it was pretty fast and simple and easy to go ahead and make these provisionals, even though we didn't have the benefit of a diagnostic wax-up. So that's an indirect mock-up if you don't want to do it in the mouth or you don't feel comfortable doing mock-ups on the teeth. But you can get preoperatory information, and you can also use it for provisionals, for patient feedback, and laboratory communication. The next technique, and the last technique we'll look at, is if you don't want to do either mocking up in the mouth or mocking it up on a model, you can simply send it to the laboratory. As I said earlier, the laboratory will give you a beautiful diagnostic wax-up with a putty matrix of the wax-up, and before you ever begin the treatment, you can use that putty matrix of the diagnostic wax-up to do your pre-op mock-up on the teeth. So we're going to look at an example of a case where we did exactly that. This is what we call the indirect intra-oral mock-up with a wax-up. So here's the case, and it's going to be a minimal prep case. The teeth are nice. They're too short. They're too boxy. They're going to be built out facially, and we want to know exactly where we need to prep teeth and where we don't. So we're going to have the laboratory do a beautiful diagnostic wax-up, which they did, and they're going to provide a putty matrix, which you see in the lower left corner, and a facial reduction guide, so we can check ourselves once we start doing our tooth reduction. So the first thing we're going to do is we're going to take this, and you see when we put our facial reduction guide in, you can see that there's a lot of room facially, so we're not going to have to take a lot of tooth away. But we'd like to know exactly where the facial contours are going to be, so we're going to do a mock-up before we ever begin our preparations. So we take the matrix that's been made from the diagnostic wax-up, we're going to put our temporary material in there, and we're going to, with no spot etching, no bonding or anything, we just seed just a little bit of material, and we're going to seed it right over the teeth before we prep the teeth or done anything to the teeth. And we remove that, we now have a mock-up. And I said earlier, you want to be, when you do little or no preparation, don't put a lot of material. You can see why we recommend that in the bottom right picture. Got a little too much material in there, and you see a lot of excess, which needs to be removed. It's not a big deal, but it makes life easier for you if you don't use too much material and get a lot of excess. So now we have our mock-up. We can evaluate. We haven't anesthetized the patient. We can have them remove the excess. We can have them smile. We can look at incisal ledge position. We can look at length of centrals. We can look at buccal quarters. We can have the patient, make phonetic sounds to check to see if they can speak okay with the new tooth position. We can look at function. We can have them tap on articulating paper and go in excursive movements. There's a lot of information we can gather before we ever begin treatment. And we can let the patient look at it and get some type of patient feedback. Next thing we do before we ever remove, and here you see an example just how much we move, how far we move these teeth facially. We brought those out from mocking this up, and all this excess you see on the lingual, that would be removed. And then before we remove our mock-up, again, just like you saw in previous cases, we're going to do our depth cuts. And what the depth cuts will tell us is exactly where we need facial reduction and where we don't. So once we remove that material, the excess material, we see our depth, we'll color in our depth cuts, and you see exactly where the burr needs to touch the tooth and where it doesn't. And in tooth number 8, you can see we did a little bit of minor gingival recontouring with our diode laser, just the slight amount, the information we also gained from our mock-up. So here are our tooth preparations, all in enamel, very minimal preps. We're going to use a lock-on technique to provide our provisionals here. And here you see an occlusal view, and you can see we have some interproximal elbows. We have a little bit of facial reduction, but very, very little. This is going to be what we call a minimal, very minimal, not a true no prep case, but a very minimal case. So again, just like we did before, we're now going to use the same matrix, but instead of for our mock-up, we're now going to use it for our final provisionals. So this time we're going to use the lock-on technique. We spot etch in the center, as you saw earlier with the lock-on technique. We reseed our tray with our same material just like before. We're going to take it out. Again, we got a little more excess than what we'd like. We trim away this excess. We shape the teeth. We polish. We open the incisal and gingival embrasures, and we polish these up, and now we can evaluate. And because this was a minimal prep and we were all in enamel, we didn't even have to anesthetize the patient, meaning we can evaluate the temporaries right on the spot. We can go ahead and look at her that day. We can see her smile, we can take pictures, we can take impressions, and all this information of the provisionals that you see, the after of the provisionals done the same day right there, and we didn't have to get her back for a post-op. Normally for provisionals, we like to see the patient 24, 48 hours up to maybe even a week later when the anesthesia is gone, the lip is not numb, they have a chance to get used to them, speak with them, eat with them, and so we can evaluate them better. So this is kind of where we're looking at our provisionals as a guide to the final restorations, and the more information we can get from the provisionals, the more we can communicate with the laboratory and with the patient. So it's critical. So here we've seen a couple of different techniques that we can use, whether you like to do it yourself, you don't like to do it yourself, you want to rely on your laboratory, you don't have time to rely on your laboratory. There's a different technique out for you no matter what your preference is. So let's run back through this again real quickly. Mentioned it earlier starting off, but again, the benefits of a mock-up are it can help determine incisal edge position. Determining incisal edge is the parameter upon which the rest of the treatment is built. So it's the first and most important thing we can do in any anterior aesthetic case. And a mock-up is critical for determining incisal edge position, and we'll show you how we do that in a couple of cases in just a minute. It can also help establish proper arch form. We'll show you a case how we did that. It can be used to establish gingival height symmetry, tooth proportion, and facial contours. We showed you an example of that in the mock-up we did on the case with a patient that had the peg lateral on number 7 and the canine substitution number 11 for the missing congenital lateral number 10. All this information we were able to gather through our mock-up. It will help evaluate aesthetics, function, phonetics. We were showing the example of how we did that. It can also be used as a template for provisionals in some of these cases where you don't have time or you don't want to get a diagnostic wax up. You can take an impression of your mock-up, and we can go ahead and send that to the lab. We don't have to send that to the laboratory. We just set it aside, and we can use that to make the provisionals from. It can also be beneficial for laboratory communication and patient feedback. So this is important in cases where you're going to be doing a big case, we're going to be doing multiple teeth. You're going to want to know what the patient feels before you commit to the final restorations, and you also want to give the laboratory a really good idea of what you're doing if they haven't made a wax up for you. And it could be valuable for case acceptance. In the example I showed would be where a patient may not know what the possibilities are, and if you mock it up without having to touch the teeth, you could actually give them an idea. So here we're going to use our mock-up to determine size. I'll show you a couple of cases that we use, one a wear case and one where there wasn't enough incisal display. And in both cases, we had to lengthen teeth, but we wanted to use the mock-up to determine how much we lengthen the teeth. So here we see the first case, and this is a patient on full smile, and we can see that because of wear and because of the color of the teeth, the patient is unhappy with the smile and unhappy with the appearance of the teeth. So the first thing we do when we're mocking this up is we want to determine where incisal edge needs to be. And before we add our flowable, we look at our lip at rest. And the lip at rest is a good determinant of where the incisal edge needs to be. And for a patient this age, we know he should be showing some tooth at rest, probably somewhere around 2 to 3 millimeters. Since he isn't showing any tooth at rest, we feel like if we were to build these teeth down, it would give us a starting point. So we're going to add a little bit of flowable composite. We're going to look at his lip at rest again, and we see that we're now kind of in the ballpark. All it does is give us a starting point. In this case, because we're going to be working without a wax up, and we're going to go ahead and complete the treatment that day, we go ahead and mock up the entire smile so we can take an impression and set that aside and use that as the matrix for our provisionals. But the most important thing we did first is we determined incisal edge position, and we used our mock-up to help us determine that. So here we see the final mock-up, and we see we mocked up all the smile because we're going to use this to make our provisionals. But it's also possible that they could wear this mock-up. You could actually have them go home with it and have a spouse look at it or evaluate it or let them look in the mirror or whatever they think and check it out. Have them come back and see how they speak, see how they're functioning with it before you ever do any further treatment. You could also take an impression and send it to the laboratory for a diagnostic wax-up. When I do this, I normally only do 2 to 4 teeth. It doesn't make much sense if you're going to use the determining incisal edge position and you're going to get a wax up to go to all the trouble to mock up the entire smile. So in cases where I'm going to determine incisal edge position with a mock up, I usually only do just the centrals and sometimes the centrals and laterals. That is critical information for the laboratory, and it really helps them when they're lengthening teeth to know exactly where to put the incisal edge and how long to make the teeth. And we could also, in this case, what we have to use it for, and also in cases we've shown previously, is we'll go ahead and take an impression of this, we'll set it aside, we'll make our depth cuts, and we'll go ahead and start beginning our preparations. In this case, the patient came in, was unhappy with her smile, and she felt like she didn't show enough tooth when she smiled, and she didn't see teeth on the side. So we call that inadequate tooth display, and we call that negative space or negative buccal quarters. So when we looked at her lip at rest, we saw that there was no display at rest. Not only that, we took a perioral probe and we realized she was -2 underneath her lip. So we knew we were going to have to get 3 or 4 millimeters of length just to know if we would be in the ballpark or not. So what we did in her case is we went ahead and mocked it up just to see how it would look and to see if we lengthened these teeth about 4 millimeters, would she be able to tolerate that length. So here we are, we're just seeing, are we in the ballpark? Here we are, we're mocking this up right over the porcelain, we don't etch, we don't scratch the porcelain, we're just mocking it up. And here we see it after we've mocked this up. Again, we're not getting a wax up in this case, so we're going to go ahead and mock up the whole smile so she can look at it right there on the spot and see if she likes it. We then give a mirror to the patient. They're not numb, so they're able to smile, look at it. They approve the aesthetics. They say, yes, I like this. We know we're in the ballpark. We can then have them say 55, 44. We can have them say Mississippi, count from 60 to 66. We can go through phonetic sounds. We can have them write on articulating paper. We can see when they go into excursive movements. Are they breaking or knocking anything off? We can check all of this out before we ever commit to final restorations. Very critical for that. So here you see, this is the pre-op, And here's our mock-up. You can see how much longer these teeth are when we hold the lip up, but because the lip is never going to reveal all of the teeth, we know that the patient is never going to show the true length of the teeth, but by making them longer, she is able to have better incisal display when she smiles. So here's her before, here's her after with her mock-up, and this is just showing what we could do with the mock-up and showing the patient. Now, obviously, we're going to make some corrections in this. We feel like tooth number 11 might be a little too long, maybe needs to roll in. Looks like 4, 5, and 6 need to come down a little bit, and they need to roll in a little. But these are all the things, the information we can gather by taking pictures and looking at our mock-up. And here's the after. So this is the information we got. We were able to make some porcelain veneers for her, and we just bonded them right over her bridge. In this case, she had a new bridge with good marginal integrity. We felt like in this case the least traumatic thing for her was to give her more length and give her some more width by widening her out in the buccal quarters. And we were able to satisfy her request simply by mocking it up and determining where the incisal edge needed to be. So we can utilize an intra-oral composite mock-up to establish arch form also, as we said earlier when we were talking about the benefits. So here we see a case, the patient has accepted treatment, and we felt like because of the condition of the teeth, the old restorations, and because of her age, she wasn't interested in orthodontics, but we still want to be understanding that we want to prep teeth only where they need to be prepped, and not over or under prepping teeth depending on whether they're in buccal version or lingual version. So we're going to use a mock-up to establish arch form in this case. So here we can see her pre-op arch form, and here we see when we see a retracted close-up view. It's also possible with flowable composite if you dry the tissue. If we see tooth number 7 right here, it's in lingual version, and we can go ahead and we can put some material right over the tissue to determine our gingival symmetry as well. So that's what we've done. We've overbuilt these teeth just so we can go ahead and shape them back to get our ideal arch form. So we take that 68-44-014 burr, we'll go ahead and shape these teeth, and you can see there's some teeth that we've had to reduce. This is a patient that's accepted treatment. We've had to reduce some tooth structure, and then there's some teeth that when we make our depth cuts, we're not even going to get to the tooth because they're in lingual version. But it tells us exactly from our mock-up, it's established our facial contours. We're also able to determine where our gingival symmetry on number 7 needs to be. The crossbite that she was in with tooth number 7 and 27, we're able to jump that crossbite and determine where we want to be occlusally. So here we see the little arrows where it's pointing right now is showing where we put flowable composite over the tissue to determine our new gingival height from our mock-up. And then here we see it in the after, once the mock-up is completed. Little arrow. Here's a crossbite number 7, and here she is after, where we've established our facial contours and established our overbite and overjet where we'd like it to be. So again, we take an impression, we set it aside for our provisionals, we make our depth cuts just like we've been showing all along. We do it the same way every time. We color in our depth cuts, and then we go ahead and prepare the teeth. The little dot that you see there above number 7 tells us where we need to recontour the tissue to get an ideal gingival height symmetry. You can also see that on 7 and 9 there are no depth cuts in the teeth, meaning we don't have to do any facial reduction. We just have to go ahead and put a little chamfer in there, a little finish line, and roughen the surface on teeth number 8 and 10. We not only reduce the surface during the mock-up, but our depth cuts have told us we're going to have to reduce it even a little bit more. So this keeps us from having show-through in the final restoration or not having enough facial reduction by doing the facial contours with the mock-up and then going ahead and doing our depth cuts. So here's the little dot that we see. We've made a mark for ourselves telling us exactly where we need to recontour the tissue height to. So here's an occlusal view. Here's an occlusal view after the mock-up, and we can see we're able to establish an ideal arch form with our mock-up, make our depth cuts through that, and then when we see our preparations, we can see here's our teeth have been prepared, and although they're more aggressive preparations, we're going to have a uniform thickness of ceramic material on the facials of all of these teeth. So here's our final arch form that's been established through our mock-up. In the last case I'll show you just real quickly, here we see a patient with a modified triangular arch form. So we're going to establish arch form, but he also has a really dark endo tooth number 9. So we used our mock-up here for 2 reasons. One, here you see in the upper right corner the triangular arch form, and here you see that we're going to not just establish this arch form, but we're also going to use the mock-up to determine can we block out the darkness of this tooth. So when we overbuild this and we shape our mock-up back, we can see this dark tooth, because it's slightly in buccal version, is really showing through. So we went ahead and treated this teeth a couple of ways. One, we know we're going to have to be a little bit more aggressive on our tooth reduction here, but we're also going to do an internal bleach on this tooth to try to lighten this tooth, because it's very difficult with a ceramic restoration to block that out unless you use some type of opaque material, which isn't translucent and is an aesthetic. So our mock-up helped us know how much thickness of material we needed, and also by lightening this tooth, we were able to tell from our provisionals will we be able to block this out with a translucent material. And you can see here he is in his provisionals as his post-op check, and you can see that we were able to determine that not only do we have the right amount of facial reduction and better arch form because of our mock-up, but our provisionals allowed us to tell that we could use a transparent, translucent type of ceramic material and not have to go to a more opaque type restoration. So that completes the webinar portion of this exercise. We would now be happy to entertain some questions. I tried to allow about 10 minutes here for questions. I was told that if you type the questions in, I can read them here at the bottom of the screen. So if anyone would like to ask some questions, be happy to try to answer those for you, discuss anything you might have as far as a question. Okay, looks like some questions are coming in. I'm going to try to answer some of these questions. All right, how long do you schedule? First question is, how long do you schedule? There's several questions, so I'm going to try to answer pretty quick. We've got about 13 minutes left for this, so I'm going to answer these quickly. I apologize if I don't get to all of them or don't get to spend as much time. I'm happy to give out my email address. It's simply tedudney@aol.com. Please email. If I don't answer your question, I'm happy to answer emails anytime. You can go to my website. My bio is online. Please feel free to communicate. How long do you schedule for an appointment? We normally schedule a half a day for a case like this. I want to allow plenty of time. If I need to do a mock-up, if I need to do, even if I have a wax-up, I might allow a half a day, because I really want to dial in those provisionals, and I don't want to feel rushed, and I want to spend a lot of time. We're doing multiple teeth. One of the beauties of doing a big case like this is that you can spend a lot more time with a patient. Another question is here, how much do you depth cut to hide the darkness of the tooth? In that case I showed, we would probably use a 5/10 of a millimeter depth cut. I depth cut anywhere from 3/10 up to about 6/10. But my normal depth cutting burr, my favorite one, the one I use most of the time, is 5/10 of a millimeter. Another question was, let's see if I can read this whole question. Can we bill the insurance for the mock-up? I don't see why not. You should always be able to bill for your time. I apologize because I don't know the code for that, but I would assume it would be similar to doing some type of a composite provisional. Let me see what else questions I can read here. Do you use a deprogramming? I think something like the Coist deprogrammer is a great appliance to use. I think if a patient has tight muscles and they need to be deprogrammed, I think it's an excellent thing to do, especially if you're going to open somebody's bite or you're going to change their occlusal scheme. But deprogrammers, if a patient is fine and they're not having any problems, they're not having knee muscle problems, and I feel like we can get a good CR bite, I don't routinely use a deprogrammer. But I think a deprogrammer has its place. Unfortunately, the scope of this webinar does not allow me to address that question. It's an excellent one properly. What type of porcelain veneers? I love glass ceramics. My favorite porcelain right now is lithium silicate, simply because it's so versatile. I've done feldspathic veneers. I've done pressed ceramic veneers. Lucite reinforced, like Empress, I think is a beautiful material. Now lithium silicate Emax Press, which is my favorite go-to material because of its versatility, its strength, its 400 megapascals of flexural strength. It is stronger than any other glass ceramic, and it has, with the new HT ingots and the new impulse ingots, you can get really, really good aesthetics. And in combination cases where you might have veneers in the front, you might have onlay veneers or crown posteriorly, in its monolithic state, it's very strong. It's a strong restoration for posterior teeth. So I like, for my porcelain veneers, it doesn't matter depending on your ceramist. If you've got a Willie Geller type of ceramist that can stack porcelain and get beautiful work, you can't do any better than feldspathic. But pressed ceramics cut back and layered, lithium to silica cut back and layered, they all look great. Another really good question that you could do a whole webinar on. Let me see if I can get a couple other questions in here. Okay. Do we have to charge extra? Let's see. The whole question isn't coming out here. It says something about role of canine guidance. I'm assuming that you didn't mention the role of canine guidance. I see canine. For some reason, I'm not able to see the whole question here. Okay, click on the question. There you go. Thank you. Live help. All right, you did not mention the role of canine guidance or other jaw movements when you do your build-ups. Please explain. We do. We check function, we check canine guidance, we check anterior guidance, we check all of it, both in our provisionals and in our mock-ups. If I'm doing a mock-up is mainly to determine information. Our provisionals are where we check function. So when I get the patients back, we'll put them on a T-scan, we'll check for simultaneous equal intensity, bilateral stops, we'll have them go through excursive movements, we'll look for, posterior disclusion and anterior guidance. We're checking all of these things. So in our provisionals, we want our provisionals to guide our final restorations. So I think it's critical and it's very important, and I'm sorry if I didn't make that clear. Let me look at another question here. Okay. I'm going to go back to this question right here. Now that I understand, I just click on the question. Okay, good question. The question was, seems like the midline in a lot of cases was ignored. Okay, there's something very important to understand about the midline. The midline, first off, let's talk quickly about maxillary midline to mandibular midline. In 70% of natural dentitions, the maxillary midline and the mandibular midline do not line up. So maxillary to mandibular midline is not critical. It isn't in even natural dentitions. Secondly, the maxillary midline does not have to be in the center of the smile as long as it's perpendicular to the horizontal plane. That horizontal plane can be whatever your stick bite. When you get a horizontal reference, your face bow, whether it's the horizon, the interpupillary line, the incisal plane, the intercommissure line, whatever you use for your horizontal reference, as long as the midline is perpendicular to that horizontal reference, it can be off as much as 3 to 4 millimeters before the eye will register it. So that's why we don't worry about midline as long as we're sure we're getting it perpendicular to the horizontal plane. Studies have shown, there was a definitive study done by Kokich that determined that the midline could be off as much as 3 millimeters before even dentists recognized it. The problem with a midline is if it's canted, and even if it's in the center of the smile, a canted midline will always be recognized, to the eye, and it creates an aesthetic failure. So the reason we don't talk much about midline or try to correct midlines in some of these cases is that we want to be sure they're perpendicular to the horizontal plane. Hopefully that was, hopefully we answered that question. Okay, and here's another question. When you spot etch, I see you paint bond not just on the spot but the rest of the prep. Is this a problem for the final etching or bonding a permanent restoration? Very good question. We spot etch to help retain minimal prep veneers, the provisionals. Sometimes I paint just a spot etch, sometimes I paint the whole tooth. Remember this, if etch hasn't etched the tooth, it doesn't matter where that ampho resin touches. It is not going to adhere to the tooth. It's going to come right off. So it has no effect on the bond when you get them back and you remove your temporaries. The only where your bonding agent will adhere to the tooth is where your spot etch is. And because of that, a little provisional material, when you take your your temporary restorations off, sometimes you'll get a little bit of cement right there, a little bit of bonding agent, so you want to check that and maybe take a fine diamond and just kind of smooth that down, because the material will adhere to the spot etch, but not anywhere else? These are all very good questions. The last male patient you have shown, did you do veneers and a crown on the dark tooth? We did all veneers. We didn't have to do a crown on the dark tooth simply because we did internal bleaching and we were able to lighten the tooth. So we were able to lighten the tooth internally, which allowed us to use it was a slightly more aggressive preparation, but it was still a veneer. It wasn't a full crown. This question says, do you ask patient if they want better aesthetics, or they come in and tell you they want nicer looking teeth? That's a great question too. Now here's my thoughts. We do a lot of aesthetic cases, and almost invariably these patients come in seeking one thing, and that is they're unhappy with the appearance of the teeth, and they're coming in because they would like their smile to look better. So when we're providing treatment for these cases, obviously we diagnose these cases to improve their aesthetics. And when I do a mock-up, when I do a wax-up, when I do anything, when I determine size, ledge position, buccal quarters, all our smile design principles, we're setting up the case aesthetically first, because that's what drove the patient in, and that's what they're most interested in. It doesn't mean that function and phonetics aren't important, because they are, because the patient won't tolerate if they can't speak, or if they lisp when they talk, or if the restorations are breaking or coming off or not staying on, or they're uncomfortable when they try to chew. So we address all the issues. We set the case up aesthetically, but we always look at it. That's why I was showing, we get them back and they're provisionals. What we're checking for is we're checking for the smile arc and size of ledge, and we're checking for buccal quarters, and we're checking for gingival height symmetry. We check all those aesthetic smile design, but we're also going through phonetics. We're also going through function. We're also going to be checking for wear facets. We're also looking to see are they breaking or cracking or chipping any restorations. So it's all critical, but if you're asking me what brings the patient in, I think it's their appearance. I don't think most patients come in because they're worried about their anterior guidance, or they're worried about their function, or they're even worried about if a restoration fits well or not. That doesn't mean that it shouldn't. What they're primarily concerned about is their appearance. And almost all these cases that I've shown tonight, these patients came in first and foremost because they were looking for some type of an aesthetic option. Let me see if we can get to a couple more questions here. How do you control no-shows for these long appointments? Great question. I eliminated no-shows a long time ago. We get a deposit. We get a non-refundable deposit. Can you enforce it? I don't know. I don't know legally if I could, but we get a non-refundable deposit. In other words, if they didn't show up for their appointment and they said, I want my money back, they're going to have to do something, because we set aside, like I said, a half a day. In some cases, if we were doing a full mouth rehab case, we're going to be prepping for upper and lower arch. We'll set the whole day. We'll make the whole day for that patient and that patient only. So we're going to get some kind of deposit. It may be $1,000, maybe $2,000. It shows that the patient's serious. It shows that they plan on showing up, and it's done a pretty good job. Is it foolproof? No. I've not come across something that's foolproof. Have we been burned a couple times? Yes. But it's very, very rare. Hopefully that helps you. I know it's a great question, because you just don't want to make these long appointments and have the patient not show up. It's too damaging to your schedule. What kind of cement do you use? Again, we could do a webinar on cements. I have a whole lecture on the ABCs of adhesive bonding and cementation. I'll tell you really quickly what I love right now. I love All Bond Universal. I think the new universal bonding agents are great. You have to cure it on the tooth. It becomes hydrophobic after you cure it, so it's compatible with any kind of cement, self-cure, dual cure, or light cure. I love the cements. For veneers, I use light cure only, because I can cure through the ceramic. So any light cure cement. For a large restoration, it's a glass ceramic, I'll use a dual cure. Any kind of dual cure cement, because I know I can get some light cure and some dual cure. Multi-link is a true self-cure. It's a resin cement that's a true self-cure, that it has a light cure option, but it will cure in the dark. It works well under thick, like zirconia crowns. It works under metal crowns. But if you're going to use something like Dual Link Universal, which is a true dual cure, it needs to be activated with light. I wouldn't use it under metal. And as far as zirconia, I'm using a new cement called Ceramer by Doxa Dental. It's a bioactive cement. It creates hydroxyapatite formation. It's very, very easy to clean up. It sets in a gel state. It's simply easy to clean up, but there's so many good cements. It's really hard. Such a great question. So good. I'm going to end on it. I see I got about 10 seconds left. I wish I could get to more questions, but please email me your questions. I'm happy to answer them. I've enjoyed speaking with you tonight. The cement question was great because there's so many good ones. The self-adhesive cements are great cements. The resin-modified glass ionomers are great cements. Thank you for your attention, and I've enjoyed being with you tonight. Thank you.